Hello,
Hello,
here's Snežana and Mia.
and this is our very first series of talk about the surgical dilemmas.
And today we are going to focus on the connective tissue graft, in particular on the subepithelial and de-epithelialized connective tissue grafts. Mia, can you tell us more about it?
First difference is in harvesting technique. The epithelialized connective tissue graft is harvested like you would harvest free gingival graft, only it is de-epithelialized extraorally. And subepithelial connective tissue graft, it is harvested from the deeper part of the palatal soft tissue than the de-epithelialized connective tissue graft, but leaving the superficial layer for the primary closure.
It tells a lot. Primary closure, you mentioned difference in the harvesting technique, and you mentioned also the different layers of the harvesting. Whereas the de-epithelialized connective tissue graft is harvested more superficial, the subepithelial connective tissue graft is harvested more from the depth. Actually, we are familiar for a long time with the subepithelial connective tissue grafts, and the epithelialized grafts are more newcomers.
Yeah, they became like a trend.
Yes, they became a trend. I see a lot of them on Instagram, on Facebook. Why is it?
I guess because it has more volume, it looks more firm, it is, I would say, much easier to harvest it. And regardless of palatal soft tissue thickness, it can be almost harvested anytime.
Yeah, it sounds good. Let's focus just a little bit on histology, because don't be scared. It's going to be a very basic histology, and this very basic histology is going to explain differences in clinical behavior, appearance, complications that we can expect from subepithelial or de-epithelialized connective tissue graft. Uh, what are the layers of the palatal mucosa? Superficial, there is epithelium. Underneath epithelium, there is
Lamina propria.
and underneath lamina propria, there is submucosa. The epithelialized connective tissue graft is harvested superficially. Immediately below the just epithelium layer is cut off, and this graft entails lamina propria, fibrous, dense tissue. Very subepithelial connective tissue graft entails submucosa, and submucosa has a fat and glandular. And I think this is also answer why do we see a lot of de-epithelialized connective tissue grafts, yes, on Instagram and Facebook, because there is not this yellow color from the fat, and the tissue looks so healthy, so dense. This pink pale looks so much better.
Yes, indeed.
So now, Mia, you said it gives more volume, the epithelialized connective tissue graft, it should be advantage. But if I fold my subepithelial connective tissue graft, I get a lot of volume.
Yes, you do, but long-term studies are showing that the de-epithelialized connective tissue graft is more stable.
We talk about the long-term stability. Yes, it is. And this is, again, we can explain it with histology.
Of course.
Again, lamina propria compared to more fatty and glandular tissue, it maintains better the tissue volume.
And it's really good for the pontic sites.
Yes, it's great for the pontic site, but still, what I see in my daily practice, it is a color difference between the sites that are grafted with the epithelialized connective tissue grafts compared to the surrounding adjacent tissue. These sites that are grafted with the epithelialized connective tissue graft, they are more pale. Sometimes they look like a patch, almost like free gingiva graft.
Yes, and the late surgical complications can occur too.
Yes, they can. And this is interesting that these late surgical complications are described only recently in the paper published now in 2021, because until now we missed data about long-term results and complications. Yes, there are some studies published talking about cysts and epithelium invagination, but now we have really the summary of these complications showing that they are much more often with de-epithelialized connective tissue graft than with subepithelial connective tissue grafts. Which complications?
Cysts can occur, reepithelialization, then superficial epithelial band, and cul-de-sac.
What's cul-de-sac?
It's my favorite word
because it's fancy.
Yes, it means formation of invagination. So, but what
we talked about keloid. Yes,
keloid,
thank you. This is what I see. I do follow 6 patients with keloid. And I have to tell, I don't have a precise statistics, but I have harvested not hundreds, thousands of connective tissue grafts, subepithelial connective tissue grafts, and much, much less de-epithelialized connective tissue grafts. But out of 6 keloids that I have been following, 2 of them are after de-epithelialized connective tissue grafts. And I think we are going to see more of them, because the complications that we just talked about them, they are published in 2021. It is for the first time that we do have a long-term studies following the epithelialized connective tissue graft. It is rather new. I do see keloid. Keloid is a tissue, it is like hyperplastic tissue response. And we always fight to get more soft tissue volume, but too much soft tissue volume is ugly. Patients don't like it at all. It looks like a tumor. And if it's in aesthetic important area, if it's in aesthetic area, it's really terrible. And even the bad news is that we can hardly get rid of it. This is according to the publication from De La Villa and Ricci.
But you have one successful.
Yes, I do have one successful, but I wanted to say that De La Villa and Ricci, and later on Gluckman published 2 cases. They talked about 14 cases. They try to eliminate this keloid doing gingivoplastic, removing superficial part, but it came back. It came back each time. I've done in one patient excision from the inside. I elevated the flap. It was the buccal aesthetic flap. Never elevate marginal gingiva if you are not, if you don't really need to do it. Buccal aesthetic flap, and this hyperplastic, hypertrophic tissue was removed from the inside. And I've been following now the patient for 3 years after this surgery, and it's fine. It's still it didn't come back.
Didn't come back. Super, super.
Yes. And actually, all these complications can be explained again with histology. The de-epithelialized connective tissue graft means that the epithelium is removed from the connective tissue. But Harris has shown that in 80% of all grafts, there was remaining epithelium, residual epithelium. In 80% of all connective tissue grafts that were supposed to be de-epithelialized properly for the study, in 80% of them, there was epithelium. And then, depending how this graft is turned on, upside down or face on, it means if the layer that was adjacent to the epithelium is turned outwards, then we can expect more difference in the color, more pale tissue or patch-like tissue. We can expect more re-epithelialization. The cyst, we expect if this side is inwards. It is more oriented towards the bone.
But how can we remove epithel from the connective tissue graft?
The standard way is to, like you already described, is to harvest this graft and then extraorally to remove epithelium with the blade. I personally like to do de-epithelialization when the graft is not harvested, when the graft is not detached from the palatal, because each time when the tissue is firm, it's easier to do any surgical cuts. So I like to utilize mucotome, or it can be a burr, or it can be a laser, and remove epithelium layer. And then I cut connective tissue graft and harvest it. But if it's not done like this, you recently told me about the interesting approach to remove epithelium layer.
That technique is published in a clinical periodontology ebook by Newman and Caracas. Yes. And it means that you need, for a good de-epithelialization, a stable graft. So you will stable it if you put it between two wet, sterile, of course, tongue depressors, and then slice it longitudinally with a 15 blade. In that manner, you are sure, let's say, more sure that
it makes it easier. Anyway, it makes it easier when the tissue is really fixated. It's easier because connective tissue grafts, they are slippery. They are like a wet soap, piece of soap. It's not easy to handle them.
But how would I know if I have enough palatal soft tissue to harvest subepithelial connective tissue graft?
How can you be sure? Yes, it's. I think it's really frustrating when we already split the tissue and do the surgery only to realize after a few minutes that we don't have sufficient tissue thickness to harvest the subepithelial connective tissue graft. Here, I have to tell that I faced only 2 times situation where I was hardly able to harvest subepithelial connective tissue graft. How to be sure? Already doing injection, we can evaluate the soft tissue thickness. If we are not sure, we can take a periodontal probe. Some recommend to take endo needles with rubbers and to do measurement, but surgeons don't have endo needles, but we do have a periodontal probe. But I would say it's almost historic because in the majority of cases, we do already have a CBCT from the patient. And it is important to pay attention to tell to the patient that during the CBCT scanning, the patient shouldn't place tongue on the palate and to do really exact measurements. This is important for free connective tissue graft harvesting, and even more important if we are planning to harvest the pedicle connective tissue graft. Because the tissue thickness in the area of the pedicle is very important. That it's going to decide if it's going to be a pedicle connective tissue graft or at the end a free connective tissue graft.
Yes. How can we minimize that discomfort coming from the secondary healing intention?
We can apply some wound dressings, and it's interesting again that in the literature it's very controversial. Some papers are showing that like PRF membranes or collagen sponge or histoacryl do help reducing postoperative morbidity, and the other papers report that there was no difference between control and test group. Control group without any dressing, a test group with some dressings. What I see in my daily practice is that some patients get addicted to Essex. Essex with the palatal plate, yes. It protects the site during the chewing, and it helps really.
You say that harvesting subepithelial connective tissue graft is a less invasive approach with less morbidity, but I do see morbidity.
Yes, we do see morbidity and we do see complications, but from my experience, it's really less than after de-epithelialized connective tissue graft harvesting. It is less, and complications can be avoided the best utilizing a proper technique, minimally invasive technique, because subepithelial connective tissue harvesting it does not mean immediately that it is minimally invasive. It is minimally invasive if the single incision technique is done and not trapdoor technique.
Or L technique.
Yes, trapdoor technique has two vertical incisions and they disrupt blood supply. The risk of the partial or total necrosis is big, and it is also important when the single incision technique is done that the tissue is splitted properly. It means that the superficial, the covering layer must have sufficient thickness. And this sufficient thickness must be for the entire area. It means also the wound margin. The most common failure that I see clinicians that are not familiar with this procedure, they start the splitting immediately by holding a blade parallel to the surface. This way, the marginal area is going to be very thin and to undergo necrosis. So, it's not only for the palatal tissue splitting, it is for all partial thickness flap. Our splitting starts with the incision that doesn't go all the way to the bone, but it is perpendicular to the bone. And then in few steps, the blade is angulated. And then in the third or fourth step, it is parallel to the surface and the tissue is splitted all the way. So the proper surgical technique helps to prevent a lot of, big amount of complications.
And to avoid tissue sloughing.
Yes, the tissue sloughing and also partial necrosis, total necrosis. This is all of these complications can happen.
But how to avoid hematoma?
Yes, hematoma, it is, I've seen hematoma and I've seen palatal hematoma much more earlier, I won't say how many years ago, than nowadays. They do form, and unfortunately, the palatal hematoma tend to get infected and it hurts really. I've seen hematoma not only 1 or 2 or 3 days after the surgery, after connective tissue harvesting, but also 1 week after the surgery. How to prevent them? We know from dental school, from our trainings, that we should advise the patient and that we should apply by ourselves a pressure on the harvesting area, on the grafted area for 2 minutes, 3 minutes, 5 minutes. What I think it's more important, what I figured out in my daily practice, I don't have evidence for this, but I'm pretty sure it's right thing to say. It's to advise the patient to apply the pressure in the moments when anesthesia is ceasing, in the moments when the patient starts to feel again the palate, to put the pressure, to put the wet gauze to the, and to apply a pressure in this half an hour 1 hour, because when anesthesia ceased, it means that adrenaline effect goes away. It means reactive hyperemia, and these are the moments when the pressure is very important. Done.
Thumbs up.
Thumbs up.
Very catchy phrase to finish our talk.
Yes, and to announce the next talk, now we harvested connective tissue graft. Now we do want to know how to utilize it. And this is going to be topic of our next talk. Tunnel technique, vista technique, something in this direction. See you.
See you.
Bye.